Perfect. Thank you all. So we're going to go ahead and get started. First, I just want to say hello and welcome. Thank you for joining us for our webinar today. My name is Taylor. I am the Community Training and Education Manager here at Arizona State University Office of Community Health Engagement and Resiliency. So our work within OCHR focuses on training community health workers and other health professionals in interventions that address toxic and traumatic stress for children, youth, and families. Before we get started and introduce our presenter, we want to first acknowledge and honor the original caretakers of the land that ASU resides on by sharing a video that was created by ASU's Alliance of Indigenous Peoples. And this is a student-led group that serves to represent and unite any and all self-identifying Indigenous voices here at ASU. So I'm going to go ahead and share my screen.
Arizona State University is located in Indian Country. There are 22 tribal nations in Arizona. ASU's campuses are situated on the homelands of many indigenous peoples, including the Akimel, O'odham, and Peepash.
Arizona State University recognizes the original inhabitants of these lands
and recognizes that they still reside throughout the Phoenix metropolitan area.
And we recognize the impact of their wisdom and generosity towards us.
If you've flown into the valley, you have undoubtedly seen the Salt River Project canals that surround the area.
Those modern-day canals follow the framework of the canals originally constructed by ancestral Sonoran Desert people, Uhukum, to make this area both livable and a place where peoples could thrive.
We acknowledge that the modern-day indigenous nations that descended from the ancestral peoples are the original inhabitants of this land.
Thank you all. And today our webinar topic is on intimate partner violence and its impact on perinatal mental health and anxiety disorders. And it will be presented by Teresa Wilson. So just a little bit of housekeeping before we get started. Oh, sorry, my video was playing on my other screen. So just a little bit of housekeeping before we get started. If you have any questions during the presentation, please go ahead and type them into the question box, which is in your Zoom control panel at the bottom of your screen. We will make sure that all of your questions get asked by the end of the presentation. For any other comments, please use the chat function. We also are happy that we have live Spanish language interpretation that's brought to you by the Tucson Language Justice Collective and our two amazing interpreters, Natalia and Mari. So if you would like to use the Spanish channel, please click on interpretation button at the bottom of the Zoom control panel, and then you can select the Spanish channel. So without further ado, I would like to introduce our presenter, Teresa Wilson. Teresa has worked as a perinatal and maternal and child health nurse for 40 years. Her overarching professional goal has always been to care for mothers and their families wherever she may encounter them. And she has worked in the roles of expert practitioner, advisor, manager, supervisor, consultant, and educator in hospitals and clinics, community health nursing, professional and community-based organizations, colleges and universities, international health, and a medical and legal expert. Years ago, as a childbirth educator, postpartum baby blues was spoken of with expectant parents and postpartum patients and described as a common but transient period of emotions that occurred within the first week or two postpartum. Among obstetric healthcare providers, there was little knowledge, understanding, or discussion of postpartum mood and anxiety disorders and how they affect mothers and their families. In 2004, Teresa became aware of a nursing colleague who was embarking on a project at the hospital she worked at to bring postpartum depression into greater focus through screening postpartum patients for symptoms of depression. Her work enlightened and inspired Teresa to begin teaching nurses about postpartum depression in the perinatal orientation courses she taught to nurses who were new to the care of pregnant and postpartum mothers and their infants. Over time, she became more aware and engaged in the care of women with mood and anxiety disorders in her work as a nurse home visitor in the nurse-family partnership, where she could very clearly see effects of perinatal mood disorders on clients and their families. Wanting to learn and do more to improve maternal mental health, she joined the board of directors for the Tucson Postpartum Depression Coalition, where she has been able to advocate through the work of the coalition to improve the recognition of anxiety and depression and to find resources and solutions for mothers affected by mood and anxiety disorders. And without further ado, I will go ahead and pass it to Teresa.
Thank you, Taylor. Welcome everybody to today's presentation. I started off, I want to let you know that I start with talking about domestic violence and abuse because that is very often linked to as an underlying cause of perinatal mood disorders. And it represents a continuum of stress and trauma that moms can experience. So a very common definition of intimate partner violence are those behaviors used by one person to control their partner in that relationship. It may be exhibited by abuse or aggression that occurs in a close relationship. That relationship can be between two intimate partners as well as roommates or adult relatives. And it can also include emotional abuse and threats against children. It is intentional or violent controlling behavior by both current and former spouses or dating partners. So just because a person might...
Teresa, one
Yes?
second. We don't see your screen. Do you mind sharing your screen? No.
Oh, I forgot how. Oh dear, I forgot. Sorry.
Okay.
Let's see. Okay, I'm having trouble getting back to the screen where I can do that. Let's see. There we go. Okay. All right. Can everyone see that?
Yes, there it is. Thank you.
Is that good?
Yeah, we can see it.
So, intentional or violent or controlling behavior by both current and former spouses or dating partners, which means that even if a person leaves a relationship, that doesn't mean that the abusive partner won't keep trying to engage with them. IPV does not require sexual intimacy to be an intimate partner violence, and violence exists along a continuum from a single episode of violence that could have lasting impact to chronic and severe episodes over multiple years. An intimate partner can be a current or former spouse, partner, boyfriend, or girlfriend. And survivors of domestic violence and IPV come from every age group, religion, ethnic or racial group, socioeconomic group, educational level, sexual orientation, or gender identity. And in short, no one is immune from domestic violence or intimate partner violence. It could happen to anyone. IPV is characterized by coercive control behaviors because it is the goal of the controlling partner to have control over the other person. And to achieve that, they may use physical violence, sexual violence, threats of physical or sexual violence, reproductive coercion, psychological or emotional abuse, which includes progressive isolation from family, community, or support groups, and intimidation, as well as economic abuse. So it doesn't have to involve hitting or what we used to call battery. It can involve several different behaviors that combine together to maintain control over someone. And many years ago in the 70s and 80s, we looked at family violence or domestic violence as a personal problem. And so people were hesitant, well, number one, to share it, but number two, if someone was aware of that kind of behavior, our society tended not to intrude because we felt it wasn't our problem. It really wasn't our business. But in truth, it is a public health problem that affects all of us in indirect or direct ways. We know from the CDC that nearly 1 in 5 women and 1 in 7 men report having experienced severe physical violence from an intimate partner at some point in their lifetime. And that about 1 in 5 women and 1 in 12 men have experienced contact sexual violence by an intimate partner. And I just want to say one word about the reporting between men and women. One thing we do know is that violence is often underreported, and especially for men or marginalized communities, because they're afraid they won't be believed, or because of the shame that many people feel to be in a relationship like that. 10% of women and 2% of men report having been stalked by an intimate partner. And over 43 million women and 38 million men have reported to have experienced psychological aggression by an intimate partner in their lifetime. And really, by far, the more common kind of abuse is the psychological aggression rather than the physical battery and hitting. But there is also a societal impact of IPV in that 41% of female IPV survivors and 14% of male survivors experience some form of physical injury related to IPV. U.S. crime reports suggest that 16% or 1 in 6 homicide victims are killed by an intimate partner. And that is something that those are the occurrences that actually make it into the news or into your local paper. If you read the paper, that is the ultimate outcome of perhaps years of violence is death. And very often this happens when a victim or survivor, and I use those terms interchangeably, is trying to leave the relationship. The cost to society of IPV over a victim's lifetime is estimated to be over 100,000 for women and 23,000 for men. The economic cost of IPV to us in general is $3.6 trillion related to the cost of medical care, mental health services, loss of productivity due to time away from work because the controlling person is maybe wanting to make the partner more dependent economically and makes it difficult for him or her or for them to go to work. And then the cost to the criminal justice system when if there's an arrest and prosecution of an abuser. So what underlies abuse in relationships? And this is a question that I would get a lot from my fellow nurses. And the key point is power and control. One person needing power and control over another. And really, it doesn't have to become physically violent because threats and violence work. Controlling behaviors also reinforced within our society from friends or family. If that person, if the victim grew up or the perpetrator grew up in a family where this was routine, that one partner had control over another. And then in many ways, our society reinforces these beliefs that this is normal in a relationship in a lot of the media that we see, like film, movies, and television and other media like that. So abuse is about having control over others, and of course physical abuse is more obvious, although less common. But the difficulty is that emotional abuse is more difficult to acknowledge. Many people may think that being abused means that you're being physically abused. And so because they become brainwashed by their controlling partner, you may not recognize the emotional abuse as it's happening. And very often the emotional abuse will be rationalized as or normalized by the perpetrator. Economic abuse delays separation from the abuser, because especially if it's a woman with dependent children, because being in that relationship provides a certain amount of economic security for them and their children. And so it makes it very difficult to leave, to contemplate maybe living on the street with their children, or perhaps they don't have anywhere else to go. And very often part of the technique that the perpetrator uses is to isolate the survivor or victim, and I use those terms interchangeably, is isolated from, is isolated from their family and friends. And some of that derives from the difficulty kind of dealing emotionally with someone in the family who's in a relationship like that. If you have a friend or a family member and it's a real back and forth seesaw in their relationship. And oftentimes people can get empathy fatigue and find it difficult to keep relating to the survivor, which increases their isolation. But one thing we know about violence is it almost always gets worse without intervention. So talking about the physical realm of violence, it may start with, pushing or wrestling, quote unquote, and increase in violence to shoving a person into a chair or a door, or using a weapon, weapons in the home like a knife or a screwdriver or something else, pulling her around by her hair or their hair, to homicide. Verbal abuse is really soul crushing, continuous name calling, ridiculing, telling the survivor over again that they're no good and they can't do anything right, things like that just chip away at the soul of the survivor, which can compound existing depression or anxiety and increase depression and cause the person to feel just hopeless and helpless, which can lead to suicide. And then sexual abuse can run the gamut from unwanted touching to rape, or forcing that person to engage in some other sexual act that the survivor does not wish to engage in. So we know that people experiencing IPV have significant short-term and long-term health care problems, particularly mental health problems. That's why it can be a precursor for someone who grew up in an abusive home, or is in an abusive relationship, or has been, to be more likely to experience depression, anxiety, eating disorders, even psychosis, especially if they have behavioral health problems already and are being controlled and manipulated by a perpetrator, and then suicide ideation and attempts, because the survivor feels like there's no way out and there's no future for them. 4 to 8% of women report violence during pregnancy. This statistic is from the American College of Obstetricians and Gynecologists. And we have to remember that many women are not going to report during pregnancy because they're afraid or ashamed. So in all likelihood, the rate of violence during pregnancy is higher, but this is what is reported. And it can take two forms. It can be business as usual, because the relationship is already one of coercion and possible physical violence, or pregnancy-specific violence directed at the child that the woman is carrying in her womb. And so the violence may be a display of the jealousy and anger that the perpetrator has toward the unborn child, because the controlling partner wants the attention of the survivor on them all the time, and all their emotional energy of the survivor directed at the controlling partner. And when a woman becomes pregnant and knows that she's pregnant, she begins to develop a relationship with that child. And that takes away from the emotional attachment she has to the perpetrator. So that is why the hitting the woman in the stomach or the breasts, pushing her down the stairs, trying to force a miscarriage even, would be characterized by that pregnancy-specific violence. So the risk factors for violence during pregnancy include young maternal age or an adolescent girl, an unintended pregnancy, although only 50% of pregnancies are intended. Most of them are not totally planned or are hoped for. And they can be characterized by delayed prenatal care, possibly because of the control, economic and otherwise, that the perpetrator has over the pregnant woman. And if she has had a history of sexual abuse as a young girl, she's more likely to be using drugs and alcohol before and then during pregnancy. That is a very strong risk factor for drug use during pregnancy, is childhood sexual abuse for young girls. And because of the social isolation, she may not have the social support that every pregnant mom and postpartum mom needs. And also with a perpetrator or a controlling partner who has a more active social life than the pregnant woman, they may bring home STIs, HIV, or AIDS to that pregnant woman, which of course affects the baby as well. Some of the effects of abuse on pregnancy are related to the psychological and the physical trauma, and they affect both the mom and the baby. Very common might be a miscarriage, if not from a violent treatment of the pregnant person by the controlling one, perhaps from the anxiety, which increases inflammation in the woman's body, which could be a precursor to preterm labor, with the stress, maybe possible assaults or even STIs. And also by not getting, by a mom who can't get to prenatal care as early as she might because of the controlling partner. So that predisposes her to miscarriage or harm to the fetus. And then she may not be able to buy the food that she needs to have a healthy pregnancy, again, because of the control by the partner. And she may have a nutritionally deficient maternal diet, which leads to low birth weight. And then the ultimate effect of abuse on pregnancy can be death from homicide. So the stress of abuse during pregnancy and possibly a nutritionally deficient diet can lead to decreased or low infant birth weight, which makes it harder for babies to make that transition from intrauterine life to extrauterine life. Very often, the chaotic lifestyle means that there's financial insecurity or having to move a lot or a lot of fights and distractions during the pregnancy with housing problems. Again, substance abuse or use during pregnancy to self-medicate from the trauma that the mom is experiencing. Along with the chaotic lifestyle and housing problems can come sleep deprivation and neglect of the mother's own care. So all of that trauma and tension increases the inflammation process in the woman's body. And that increases her susceptibility to infection, which is lowered a little bit with some, especially viral infections. Pregnant moms don't have as much immunity to some of the viral infections that she might be exposed to. And also all that psychological and physiological stress causes the mom's blood vessels, all the vasculature to vasoconstrict. And during pregnancy, as the pregnancy progresses and the baby grows and the placenta grows, the mom's blood volume increases by 50% to support the baby and the uterus during pregnancy. So what the mom's body naturally should do is vasodilate, have all those blood vessels and capillaries that go to that are carrying oxygen and nutrients to the baby via the placenta. We need those blood vessels to be opened and dilated to accommodate the extra volume of blood circulating and the delivery of oxygen and nutrients to the baby. But instead of that, a mom who's very stressed, she will vasoconstrict. So that decreases blood flow to the uterus and to the baby. That in turn can result in preterm labor and delivery, and also the maternal catecholamine release influencing the fetal nervous tissue development affects and disrupts the fetal autonomic nervous system. And the catecholamine release comes from the stressors, the constant stressors that a woman in a abusive pregnancy, and especially during her abusive relationship during her pregnancy, that's how her body reacts. Her autonomic nervous system reacts to yelling and being pushed and being abused by releasing catecholamines on a regular basis. And so that's harmful to her autonomic nervous system. It's also disruptive to the baby's autonomic nervous system. And we used to really just focus on, back in the day, on the abuse during pregnancy, because, the goal was to get the mom to deliver a healthy baby. And for a long time, we really weren't paying attention to the postpartum risks that mom and baby face. So because now we know it's also a time for increased risk for abuse or homicide, because on a controlling partner's point of view, it was bad enough perhaps in pregnancy that the mom was preoccupied with the baby inside her. Well, once she delivers that baby, the baby's there. That baby needs, attention and feeding and care 24/7. And so that might increase the jealousy that the controlling partner feels toward the baby, and the abuse towards the mom may also increase. And there's also increased risk of sexual abuse, a partner not wanting to honor that 6-week pause of sexual relations after a delivery. So for those of us who work in the hospital with postpartum moms, or who are doing home visits with postpartum moms, it's essential that we continue to assess for possible abuse in the postpartum period as well. And of course, if a mom is being abused, and she's home with a baby and physically hurt, that increases by a great magnitude the risk for her to have postpartum depression sometime in that first year after delivery, especially if she herself isn't getting adequate rest and nutrition, which she needs to have a supportive community or partner around her so that she and the baby can thrive. And one of the goals of a perpetrator may be to disrupt the bonding between a mom and her baby, because they want the attention going back to them and not on this baby who requires so much care and attention. So that puts not just the mom, but the infant at risk for physical harm. And a special class of women, young women who are at risk, are teenagers, because we know that their prefrontal cortex, their executive part of their brain that is able to distinguish risks in life, is not developed in a teenager. And it doesn't really fully develop in young women until about the age of 24, and in men in the age of 26 on average. So teenagers are much more vulnerable to abuse as a teenager. And the CDC reports that nearly 1 in female teens and 1 in 15 male teens have experienced physical dating violence in the last year. And 1 in 9 female and 1 in 36 male high school students have reported sexual dating violence in the last year. And we know that through the CDC data, that 26% of women and 15% of men have reported having experienced intimate partner violence for the first time before they were 18, at some time in high school. So what we know is that youths who are victims of violence, and that could be in the home or through a dating experience, are more likely to experience symptoms of depression and anxiety, which they self-medicate through unhealthy behaviors like using tobacco, drugs, and alcohol, or they exhibit antisocial behaviors and think about suicide. And this was all reported before COVID. And we know that there's a huge increase in anxiety and depression in teenagers since COVID. Teen dating violence can occur now, not just in person or electronically. So bullying on social media is very widespread and can be very vicious, and it's hard to get away from. You can't avoid social media very easily if you're very engaged in it, as we all are. Female teens in a violent relationship are at especially high risk for manipulation and coercion into having sex or using drugs or some other unhealthy behavior. Because their prefrontal cortex hasn't developed enough for them to be able to have the self-confidence and to recognize what would be risky behavior. Many of the risks for dating violence is, number one, the belief that dating violence is acceptable because you have a friend involved in dating violence, or you've experienced it or witnessed it at home. Young girls especially are vulnerable to depression and anxiety, more so than boys, and other trauma symptoms. They may be at risk, especially if they've had their boundaries over their body taken away from them. at an early age because of early sexual violation, then it's very likely that they will experience or engage in early sexual activity and have multiple sexual partners. And we turn to substance use to kind of self-medicate for all the confusion and trauma that they experience. An unwanted or mistimed pregnancy is also a big risk factor for violence, especially among pregnant teens. 60% of sexually abused teens also have been hit by their partner. So the two go together. They're very closely linked. And prior sexual abuse is very linked to adolescent pregnancy. And according to the CDC, and this was 2007, 13 to 26 of pregnant teens have a history of sexual abuse. So that's a very strong risk factor. So a lot of times when I would be talking to nurses about domestic violence, especially like if we'd be sitting around the nurses' station and talking, they would ask me, well, why did the victim stay? I wouldn't do that. And this was said to me by several people who were in economically abusive relationships but didn't recognize it or something like that. But the main thing is that they love their partner. It's a relationship, and they want the relationship to work. So they are also afraid of escalating violence if they leave, and that's a very valid thing to be afraid of. That shows emotional intelligence and good self-care to have that fear. They may be emotionally and financially dependent on the perpetrator, lack support from family or friends, and there is not as much societal support as there should be. There are far more refuges and shelters for animals than there are for women and children. Granted, it's a far more complex question, but traditionally we haven't really supported those moms societally. One of the things that has been discussed for several years among the community that provides support for domestic women, people, anyone who's been involved in a domestic violence relationship, is why is it that the victim or the survivor has to leave the home and the perpetrator gets to stay? That's something that they're trying to address, but that's a very complex, difficult problem to solve. And one of the things, and the other thing is, most of the time, their home life is tolerable, like 90% of the time. So they want to keep the relationship going, and they're willing to put up with the 10% that's not acceptable to have a happy home life 90% of the time. And they believe that the violence is temporary, caused by stress. And yes, it's true that outbursts of violence may be caused by stress, but the underlying violence and control behaviors are not caused by stress. They're caused by a deliberate program of brainwashing almost. And very often survivors believe that they caused the violence because that's what the perpetrator tells them. It's your fault. I wouldn't have done this if you hadn't, if you'd cooked the rice correctly, or if you'd done this, or if you cleaned the house right, or if you kept the kids quiet, it's your fault that I had that outburst. And the survivors or victims are the nurturer within the relationship. So they feel that they should be able to help their partner control their abusive behavior, or because they grew up in a home where violence was normalized, they believe it's part of every relationship, and it's just something, if you want to be in a relationship, that you're going to have to put up with. And also because leaving the relationship is the most dangerous time for the survivor. And that's why a survivor leaves and returns to a violent relationship several times, average of 7, before leaving the relationship for good, because they are surviving. They know how to survive that relationship. And also because to leave, especially if you have dependent children or if there's any economic dependence, it takes a lot of planning to have your ducks in a row. and to not only leave safely, but to leave so that you have some financial resources and you're not just out on the street. But the other thing we need to remember is we need to empower the survivor. If it's someone we're working with in our work relationship, it needs to be the survivor's choice. And by trusting their judgment, by going along with their plan and supporting their plan, we are empowering, not victimizing that person. And just the fact that they've survived this long is proof that, you know, they should be in charge. And there are so many areas in the relationship with their controller that they may not be in charge. This is a very empowering, although paradoxical, plan to take. So I'll be going on to PMADs shortly, but I wanted to review adverse childhood events, and I'm sure that most of you have had training in trauma-informed care and ACEs, but I do like to use this as a bridge from violence, IPV to PMADs. Adverse childhood experiences. Well, childhood experiences can be both negative and positive, and we know that they have a tremendous impact on future violence and victimization and perpetration, and lifelong health and opportunity. ACEs, childhood experiences, have been linked to risky health behaviors, chronic health conditions, low life potential, that is, they won't have a healthy life, and they may have an early or untimely death. The original study was conducted at Kaiser Permanente, I think in the San Diego area, and it was one of the largest investigations of childhood abuse and neglect and later life health and well-being. Over 17,000 HMO Kaiser members from Southern California received physical exams and also completed confidential surveys regarding their childhood experiences and current health status and behaviors. So that's how the ACEs screening tool came about. The original study was conducted from 1995 to 97, and so the questionnaire in the original Kaiser study used a 10-item tool to measure childhood trauma, and I expect that many or most of you are familiar with it. It collected information on child abuse and neglect, household challenges, and other socio-behavioral factors. There are 10 types of childhood trauma that are covered through the ACEs questionnaire: physical, sexual, and emotional abuse, emotional and physical neglect, and household challenges such as substance abuse in the home, separation or divorce, mental illness, mother treated violently, and having an incarcerated household member. So those were the 10 areas that the ACEs tool is intended to cover. And the score assesses the total amount of stress based on those 10 types of childhood trauma or toxic stress. And the score is based on the sum of the number of ACEs that are reported, so 1 to 10. And with the ACEs screening, as the number of ACEs increase, so does the risk for negative health outcomes. There are subsequent variations of ACEs surveys that have been developed to focus on certain populations, and they include toxic effects of racism, witnessing violence outside the home, bullying, losing a parent to deportation, living in an unsafe neighborhood, and involvement with the foster care system. And here's an illustration of the ACEs pyramid. It shows the mechanism by which ACEs influence health and well-being throughout the lifespan. So at the bottom of the pyramid are adverse childhood experiences, and we know that as though children experience those stressors, their body secretes catecholamines, the stress hormones, which disrupt neurodevelopment and can start, as we discussed, or I've discussed, during pregnancy, if abuse occurs during pregnancy. And out of that disrupted autonomic nervous system come social, emotional, and cognitive impairments, which often will lead to the adoption of health risk behaviors, which are sort of like self-medicating for the stress and confusion and often disorientation some people may feel. And those health risk behaviors, on top of some of the health risk behaviors, will lead ultimately to increased disease, disability, and social problems. And that all of those together can culminate in early death. So that is the mechanism for ACEs. The impact of ACEs and IPV on mothers and infants show that there is a threefold increase in the odds of high levels of symptoms of perinatal depression, anxiety, and PTSD in women who have experienced IPV before or during pregnancy. A threefold increase, which is pretty strong. ACEs and IPV are linked to adverse physical and mental health problems for both mothers and infants. So what can we do about ACEs as a society? Number one, home visitation with pregnant women and families and newborns. Those are such effective techniques or programs because, as you know, if you're doing home visitation, you're in people's homes, you're meeting them where they're at. And that has a much more profound effect on you, the care provider, because you understand and see the factors that are affecting families much more clearly if you see them in their home rather than in a clinic or in the hospital. And you can develop a stronger relationship with your clients. Parent training programs like Parents as Teachers, Healthy Families are all very important programs because many young parents may not have been reared or parented by people who were very good at that. And so these parent training programs help us break that intergenerational flow of bad parenting for families. And also helps with domestic violence and IP prevention or detection and prevention, provides social support for parents, empowering parents to, take pride in what they're doing with their children. Parent support programs for teens and teen pregnancy prevention programs are very important because teens psychologically are a different population altogether. So those support programs for teenage pregnant young women are so very important. Also, mental illness and substance abuse treatment, which are both of which are very far and few between, and quality ones are often hard to find. High quality childcare and preschool are hugely important for all children. And I think our Congress is beginning to cotton to that idea and realize that high quality child care should be every child's right and should be affordable and accessible to all children who need it. And ACEs, by giving sufficient income support for lower income families, can also ease some of the stressors. So PMADs, I'll call them PMADs. It's perinatal mood and anxiety disorders. And it doesn't really include the baby blues. Baby blues are not a mild form of depression, and I'll talk about that in a little more detail very soon. But they include depression, anxiety, and panic disorders, which are grouped together, which include obsessive compulsive disorder, or OCD, panic disorder, and post-traumatic distress disorder, PTSD. That also includes bipolar disorders, both type 1 and type 2 bipolar disorders, which many women may have experienced, either diagnosed or not diagnosed, before pregnancy, and then postpartum psychosis, which is very rare but very dangerous. So perinatal mood and anxiety disorders are associated with adverse effects on the fetus, just as IPV is, perinatal and infant death, postpartum psychopathology, and subsequent behavioral and emotional problems in the child who's exposed to the stresses that the mom is experiencing. The outcomes of untreated mood disorders are a major public health issue with impact on the entire family. And one of the things, at least here in Arizona, that a special task force has uncovered is that Arizona has a very high rate of maternal mortality in the first year after delivery, much of it due to perinatal mood disorders or mental health disorders. And that's something that now that those findings are released, that they're starting to look at and look for interventions to help with that, at least in Arizona. The prevalent PMADs are the leading complication of pregnancy and childbirth. And I used to think, this was a surprise to me, I have to say, as an experienced perinatal nurse, I always thought it would be like preeclampsia, the blood pressure from preeclampsia, or hemorrhage at the time of delivery. But PMADs are the leading complication of pregnancy and childbirth. It occurs in 1 in 5 mothers, and the onset can be between 4 weeks postpartum and 1 year postpartum. And one of the things that ACOG, the American College of Obstetricians and Gynecologists, are looking at is to redefine postpartum and not confine it to the first 6 weeks postpartum, which was traditionally how we looked at it, but to define it as the first year postpartum, especially for a first-time mom. But so when I speak of postpartum, I'm talking about that first year. And we do know that prenatally, about 20% of all women have depression and or anxiety, and it may or may not be diagnosed. So 20% of moms are predisposed on the basis of having depression or anxiety, and that puts them at higher risk for postpartum, for PMADs, postpartum depression or anxiety. So risk factors for PMADs, the two most important ones, or the most common ones, are a personal history of behavioral disorders and substance abuse, or a family history of behavioral and substance abuse. And of course, this is how we can see that ACEs tie into that as well, because of the family histories, and a history of trauma. And there are the ACEs again, childhood trauma and neglect, and sexual and other trauma. All of those are very strong, really the most common risk factors for a woman developing a PMAD in the postpartum period. So a history of domestic violence, or IPV, a history of premenstrual syndrome, PMS, hormonal influences during pregnancy and right after pregnancy, because once the baby's born and then the placenta is delivered, the hormones of pregnancy, which were circulating at fairly high levels to keep that pregnancy healthy, just plummet after the placenta separates and is delivered from the mom. So that's what contributes to the baby blues, those early ones. But often that hormonal shift, dramatic though it is at delivery, does kind of settle down after a few days or a couple of weeks. Moms with less than a high school education are at higher risk because they have less knowledge of community resources and ways to find help and support for themselves during the postpartum period. Of course, adolescent mothers we've talked about already, and single moms. Again, they may have decreased access to social and community support. Previous pregnancy loss, any kind of previous pregnancy loss and grieving process, either through infertility, either through inability to conceive, or having gone through the whole process of infertility where you implant a fertilized egg and then it fails. I mean, for a mom or a couple going through that, that's like a pregnancy. That is a pregnancy loss. And it's a very, very difficult process. Unwanted pregnancy, a difficult pregnancy, high risk, where there are restrictions in mom's activity, or she has to, or there's threat to the viability of the baby, and she has to be seen by specialists, and there's a lot of stress, of course, involved with that. A long and difficult labor can be very difficult and end in a traumatic delivery. Even if there's a good outcome in terms of the baby, the experience of the mom of a long and difficult labor and or a traumatic delivery, like with forceps, or having to rush back to the OR and have a cesarean delivery, those are very traumatic for moms, because that's not what they were planning or hoping or imagined for themselves when they were pregnant and thinking about delivery. Having a baby admitted to the NICU is incredibly stressful and terrifying for moms, and breastfeeding difficulty. Most moms want to breastfeed, but not all babies are able to latch on right away, or have a good suck or swallow, and it can be very fatiguing and self-defeating for moms if they feel like they're failing, and I'm putting failing in quotes, at feeding their baby. So baby blues is the non-disorder, and it affects 50 to 80% of new moms. It's again due to the extreme hormone fluctuation at the time of childbirth. It'll peak about 3 to 5 days after delivery, but should not last any more than 2 weeks after delivery. And one of the things that exacerbates it is acute sleep deprivation, which is so common in being at home, being maybe, sore from your delivery or your C-section, and taking care of a baby. It can be really, you're going to feel very crazy and sleep deprived and fatigued after that. The symptoms in the mom include crying, emotional ability, very reactive emotionally, feeling overwhelmed with motherhood, well, all of which can kind of like build and make her feel like she's not a good mom, and very uncertain about whether she really can do this. And it can also, even this can affect a mom's ability to bond with her baby, all of these things taken together. So she really needs a lot of support and reassurance during baby blues. They're not to be ignored, but if it resolves within 2 weeks, she's probably going to be okay, but not without a lot of support and love and care. Symptoms of depression, which will exhibit usually about from 4 weeks to the end of the first year of postpartum, include sadness and crying, unexplained physical complaints, suicidal thoughts, appetite changes, sleep disturbances, inability to concentrate or focus very well, being very reactive and irritable and angry, and then feeling hopeless and helpless. The hopelessness and helplessness are key signs in depression, where the woman just feels totally defeated and unable to cope and be a good mom. And then she'll feel guilt and shame for maybe not, and this also interferes with bonding with the baby. So she'll feel guilt and shame inside of her because she isn't feeling that connection to her baby that she'd hoped she would. In general, she's just overwhelmed, not just overwhelmed, but she's feeling so overwhelmed. She may have lack of feelings toward the baby, and she's not able to take care of herself or her family. So it can add up to a loss of interest in life, joy, or taking pleasure in life. And then anxiety, feeling isolated, but knowing at the same time, this doesn't feel like me. Because becoming a mom, especially for the first time, is a huge role to take on. You become a totally different person. Your old life is behind you. You've started on a whole new phase of your life, and it can be really confusing and disorienting for a mom because of all the pressures, and maybe a mom's own self-expectations of being, quote unquote, the perfect mom, which our society imposes on moms. So she may experience mood swings and feelings of worthlessness. So I'm going to talk about the different perinatal anxiety disorders. Anxiety symptoms Moms will be more on the agitated and irritable side. She may have difficulty sitting still, have excessive concern about her health or the baby's health, like, repetitive checking on the baby and herself, and she's on high alert. She may experience appetite changes with rapid weight loss. Sleep disturbances are very common. She'll have difficulty falling or staying asleep, with constant worry that turns into racing thoughts. And some of all of that can come together and produce some physical symptoms like shortness of breath and heart palpitations. Sometimes women think they're having, a heart attack or something like that because of as the anxiety builds and increases, so do the symptoms. And panic symptoms are kind of the extreme form. Panic is the extreme form of anxiety, and anxiety can lead to panic, although not necessarily. So she may feel shortness of breath and then chest pains, sensation of choking, smothering, or dizziness, excessive worry or fear. The anxiety signs only increased, hot or cold flashes, trembling, rapid heart rate, numbness or tingling sensations. It's a real physical experience, more so than anxiety itself. She may fear like she's dying or going crazy and losing control. And it might be panic that wakes her up in the middle of the night, and she's totally disoriented. It's really, really scary for her. And then there's obsessive compulsive disorder, or OCD. It is the most underreported and undertreated disorder of childbirth, because moms are afraid to discuss or share their thoughts if they're having these thoughts about their baby. The symptoms are horrifying or embarrassing to her, and she's afraid that people are going to think she can't take care of her baby, and that she's going to harm her baby, and that she's a risk to her baby. So that inhibits the moms from just telling someone about it, even though with OCD, moms are very unlikely to ever indulge in these kind of bizarre and imagined behavior. One typical one, kind of classical one, is to put the baby in a microwave. Like the thought comes to put the baby in the microwave, or do something to the baby, or that the pet might harm the baby, something like that. So it's important, if you're around someone who's postpartum, it's to ask if you're close enough, and to ask if they do have scary thoughts, because they really need to talk about it and have someone to talk to and bounce those ideas off, and be reassured that even though she's having those thoughts, that doesn't mean she will act on them, because they're thinking maybe they're going into postpartum psychosis. But having those thoughts does not equal action. And that's something that a community health worker is well positioned to do. So the symptoms of OCD are obsessive cleaning, checking, counting, ordering your life, obsession with germs and cleanliness, checking on the baby repeatedly, even though the baby hasn't shown any signs of, baby's sleeping, but mom needs to go in and check the baby very frequently. And she's hypervigilant in regard to her care for the baby. She also may have intrusive and repetitive thoughts, usually of harm coming to the baby, or she might imagine herself engaging in those behaviors. So she feels tremendous guilt and shame that she would ever, consider that for her baby. So she's horrified at herself because she's having these thoughts. So some moms will engage in excessive behaviors to avoid harm or minimize triggers. So therefore the hypervigilance and the cleaning and the checking and things like that, because they know they're thinking that. So what can they do to avoid harm coming to their baby? Post-traumatic stress disorder, PTSD, post-traumatic stress disorder, is exposure to a traumatic event. And it may be a first-hand exposure, something that someone experienced, or it was an event, a long-term traumatic event that was repeated over and over, or an extreme event that occurred in one's life. And PTSD activates the body's natural physiologic responses to perceived threat, that is catecholamine release. But over time, having that stressor and the release of the catecholamines changes the autonomic nervous system and changes the regulation of stress hormones. So then that dysregulates the normal human development in the body, the brain, and the nervous system. Very often, people with PTSD will relive the post-traumatic events through flashbacks or floodings, and also by physical feelings. They can feel the event in their body. It's not just something in their imagining, that they see things, but they feel what they felt at the time of that traumatic stress in their body again. Those distressing memories, thoughts, feelings, or external reminders can be a trigger. Or they can just have spontaneous memories of the traumatic event, wake up from in the middle of a night's sleep, remembering the traumatic events. Often they have recurrent dreams and nightmares, and then they arrange their life around avoidance of the triggers, loud noises, bright lights, things like that they are aware can trigger their flashbacks. They'll try and avoid those. And because not unlike OCD intrusive thoughts, they're trying to hide it, and they want to be normal, but in trying to heal themselves, they may isolate themselves from family, friends, and providers, because it's so very difficult on your own to get a handle on this without treatment. So they have persistent or distorted sense of blame of themselves or others for the event, or how they behaved during the event. They may feel numbed, or on the other end of the continuum, they are hyper aroused and hyper vigilant. If it becomes more severe, they may begin to dissociate from reality as an escape from the repeated flashbacks and thoughts and body experiences. So they may also have markedly diminished interest in activities, so that that may lead to the inability to remember key aspects of the events, which is a defensive mechanism. Bipolar disorders, there are several types of bipolar and related disorders. They cause extreme mood swings that include emotional highs, which are defined through mania or hypomania, where people are really busy and running around and doing a lot of stuff, or lows with depression and withdrawal, inability, to engage or even get out of bed some mornings. Getting out of bed some mornings may be difficult. The symptoms can cause unpredictable changes in mood and behavior. And this can result in significant distress and difficulty in life because of the unpredictableness of these changes. And so these episodes of mood swings may occur rarely or multiple times a year. Bipolar type 1 is characterized by at least one manic episode, which may be preceded or followed by hypomanic or by a major depressive episode. So the onset is signaled by a manic episode, and then followed by somebody becoming a little less manic, but still kind of manic, or fall deep into a major depressive episode. The mania of a part of the episode can trigger psychosis, because they just get so wound up and go off from mania into psychosis. Bipolar disorder type 2 is characterized by at least one major depressive episode and one hypomanic episode. And the depressive episodes, as they recur, become longer and more severe. But with type 2, there are no manic episodes where people can really go off the rails. And bipolar disorder type 2 is typically diagnosed in younger people, adolescents, or in their early 20s. So this would be the more common one that you might see in pregnant women, but women with type 1 bipolar disorder are also at risk. And perinatal psychosis is the most severe and happily the most rare postpartum reaction psychologically. It occurs in 1 to 2 in 1,000 postpartum women. The onset is usually within the first 2 weeks postpartum, not the later onset. It's more acute and it has a faster onset. 50% of first-time moms with psychosis had no previous psych hospitalization until they had their baby and went into postpartum psychosis. Both type 1 or type 2 bipolar depression pose a huge risk for perinatal psychosis. It occurs in 20 to 30% of women with a known bipolar disorder. So that is a very huge risk factor for those moms. Other risk factors for psychosis is the first baby that a woman has delivered. If mom has discontinued a mood stabilizer, which happens with moms who are on psych meds, they often, have fears about the medications that they're on harming the baby. And it's hard to convince them that, the drugs are considered safe for the babies. For babies pretty much, and that more harm could come of discontinuing the mood stabilizer rather than continuing to take it. But sometimes it's hard because moms will get this fixed idea in their head that the medication is hurting the baby. Obstetric complications like a traumatic delivery or maybe going to the NICU, something like that, those are a trigger for psychosis. Of course, perinatal infant mortality, losing the baby either before birth or after birth is a strong trigger for psychosis. Sleep deprivation really aggravates and can spin out and is a strong contributor to psychosis developing in a mom. It's not the underlying reason, but it can accelerate the development of the symptoms. And of course, previous bipolar episodes, previous history of psychosis or postpartum psychosis are important risk factors for mom developing psychosis in the postpartum period. Moms will have delusions that the baby is like the baby's possessed by a demon. And to save the baby, the baby, they will harm the baby. Hallucinations, insomnia, confusion, extreme confusion and disorientation, rambling speech, rapid mood swings, disorganized thought process and flight of ideas. And I can't read the last one. Sorry. Risk factors for psychosis, again, sorry. Those are the PMADs, and it's very difficult for moms to get treatment. So that they may go untreated for their perinatal mood disorder. But we know that it's harmful to moms and to babies and ultimately to families. So if moms do not get a treatment for their PMADs during pregnancy, they can experience depression and anxiety, which contributes to functional impairment, poor nutrition, inadequate weight gain, and adverse behaviors for self-medicating with smoking, alcohol use, and drug use. The psychopathology has physiological consequences for the fetus. They can incur spontaneous abortion, bleeding, increased uterine artery resistance and vasoconstriction, which will in turn contribute to growth restriction in the baby and increase mom's inflammation and thus her susceptibility to getting an infection during pregnancy. And if there's decreased oxygen to the baby and growth restriction, the baby may have low APGAR scores or be admitted to the NICU. Also, spontaneous early labor through the stressors of untreated PMADs and inflammation, which would cause for the baby a preterm birth, which is very difficult for babies. Babies were meant to stay inside mom at least until 39 weeks, so that they can deal with the transition from intrauterine life to extrauterine life. But they may be low, those babies born to moms with untreated PMADs may have low birth weight or be small for gestational age at birth. The effects of anxiety are the constriction in the placental blood supply. And we often see in some moms like that, there will be a heightened startle effects response in the infants after they're born. They're just very hyper reactive. And also, those babies will be more difficult to console after they're born. Untreated PMADs are harmful to mothers during postpartum. We know that 75 to 80% of women experience emotional changes following childbirth. That's normal at any, whether it's your first baby, your second baby, your third baby. It's a huge change. And it's so hard to prepare for it because it's hard to know how your labor delivery is going to go. And then you're going to meet this new wonderful person. But it's also unpredictable. And for moms, that transition to motherhood, it can take some time. But 10 to 25% of moms will experience a PMAD. Women are 20 to 30 times more likely to be hospitalized for a psychotic episode in the first 30 days after delivery than at any other time in their life. So if she's going to be psychotic, and that usually happens within the first 2 weeks, but it's going to, within the first 30 days, that she may need to be hospitalized to give the supportive care that she needs if she's having a psychotic episode. And it's very hard to find a good place for moms to receive appropriate treatment while they're in the postpartum period. So that's very difficult for moms. Postpartum distress often creates future mental health issues for mom, because it'll add to or increase doubts about mothering abilities. She'll feel weak. She's not strong enough to be a good mom, and feed those already existing insecurities about herself, some of which come from society's messages about motherhood and becoming a mother, which can sow the seeds of insecurities in moms' minds. They'll feel shame about their ability to properly care for their infant because their depression or anxiety is getting in the way. They worry about bonding and attachment with their baby, and they fear the harm done to their baby during the postpartum period if they aren't living up to their expectations for being the perfect mom. And then guilt also about the impact of symptoms on the baby, the dad, and other family members. And these symptoms, if they're untreated, can last for years. It's also harmful to infants. Research has shown a positive link between postpartum depression, inadequate parenting, and child abuse. The stress of trying to parent a child while recovering from a mood or anxiety disorder often leads to frustration and can increase the incidence of child abuse or neglect over time. It may not express itself in the newborn period, but if it's untreated, as the child grows, it may lead to child abuse. So moms with depressive symptoms by the time they reach 2 to 4 months postpartum are more likely to have unfavorable parenting practices, even though depressed moms are just as likely as moms who are not depressed to follow the safety practices like infant safe sleep and bathwater temperature and using a car seat, those basic safety practices. And also feeding practices, they'll still be good at that, like giving cereal, water, and juice, breastfeeding, or feeding the baby appropriately. They will follow those, but as the baby matures and becomes more engaged and needs more input from the mom, that's when you may see a deficit. In the context of early life stress research, the developing child is not afforded much protection from the detrimental sequelae of maternal mental illness. It can deprive a child of adequate nurture in the context of stressful life events, especially with maternal depression, because it's harder for the mom to marshal the energy to really interact with her baby. And it can contribute indirectly to a child's subsequent vulnerability to illness. Research also confirms a link between maternal depression and future behavioral and developmental problems in the child. It's what a mom needs to do, or parents need to do, is engage with their baby and talk to their baby. And that takes, the first 2 weeks after you take a baby home, they're pretty sleepy and they sleep a lot because it's hard to be born. And it takes a lot of energy to enter our world and become part of it. But once the baby wakes up and their eyes are open, they're starting to focus a little, they need to have caregivers who are really engaging with them, talking to them and playing with them and things. And sometimes that is difficult for moms who are depressed. Maternal depression is the #1 predictor of future cognitive and emotional problems in the child, because it's hard for moms to really connect. Maternal depression is a significant mental health issue impeding children's readiness for school. But it starts very early on. Failure to learn and poor acquisition of associations are shown in research. Infants at 5 to 12 months in this study by Kaplan showed poor acquisition of voice-face association when they heard speech of their depressed mother or another unfamiliar depressed mother. They did learn when they heard the speech of the non-depressed male or non-depressed father. So it was the difference in affect that depressed moms or even depressed dads would have when interacting with the baby. Babies, one of the things that I would teach my moms, or we did with Nurse Family Partnership, is to narrate your life to your baby and tell your baby everything that you're doing, starting with diaper changes. And you don't ask them if it's okay if you can do that, but you tell them, I'm going to change your diaper and now I'm going to do this, and to do that with a lot of things throughout the day. That's how babies learn language. That's how babies learn to interact with their parents, and they learn some of the predictability in the flow of life. That's harder for depressed moms to marshal the energy to do that with babies. And they need it, babies need that from the get-go. Maternal depressive symptoms in the postpartum period reduce the odds of continuing breastfeeding by 27%, especially if there's difficulty getting it established. I mean, it's a two-way street, breastfeeding. It's not just the mom, because sometimes babies aren't born just naturally knowing how to breastfeed well, not all babies anyway. So it does take some work initially for some moms. Showing books by 19%, playing with the infant by 30%. One of the ways that babies learn is through playing. Playing is how babies learn when they're really young infants. They will have reduced odds of talking to the infant and following 2 or more routines by 39%. So it impedes the mom's ability to do all that because of the decreased psychic energy that she has. When a mom has a chronic mental illness, she's not the only one who suffers. Everyone in the family does. The partner, the infant, other children, and the entire family unit suffer as well. And due to the extreme stress of having a baby, however a joyful event that may be, the changes that it brings make it so that the first year postpartum has the highest rate of divorce than at any other time during a marriage. Second to that would be having a baby in the NICU. That increases the odds tremendously, because that is so hugely stressful. So there are several screening tools for depression. I'll just go over these quickly. The original one that people have used for a long time is the Edinburgh Postnatal Depression Scale, or EPDS, and I'm sure many of you are familiar with this. It screens at 6 to 8 weeks postpartum, 10 questions with 4 weighted response. The total score is determined by adding the scores for each of the 10 items. So a score of 9 or more points or any suicidal ideation should be referred immediately. If a woman scores less than 9, but the clinician feels that she may be suffering from depression, an appropriate referral should be made. The GAD-7 is another tool that's used by physicians with many populations of patients. And it comes in shorter versions. There's the GAD-5 and the GAD-2, where you just add 2 of the 10 of the questions, of the 7 questions. So, but the basic one is the GAD-7. The scores the items are scored from 0 to 3. And so the score can range from 0 to 21. And then it has cutoff scores that help direct you to know when a client needs to be referred for therapy. So the cutoff scores for mild anxiety are 5, and moderate anxiety 10, and severe anxiety 15. And we in Nurse Family Partnership use it prenatally and postpartum to screen moms. Prenatally, it gives us a baseline of where the mom's at. So we do it on enrollment. And then we do it again at 36 weeks gestation. So we have sort of a baseline before mom has the baby. And then we do it 3 or 4 times during the first year postpartum to screen for anxiety. And its partner is the PHQ, the Patient Health Questionnaire, which measures the degree of depression. So NFP uses both of these, as do I know Parents as Teachers does, at least in Arizona. And it's 9 items to measure the degree of depression. So the score can be as high as 27. Cutoff scores are for mild, moderate, and severe depression are 5, 10, 15, and 20 respectively. So, if she's got, we would try and refer her for treatment for both the GAD and the PHQ if she's displayed or scored at a moderate level of depression or anxiety with the GAD. And again, we use the 2 tools together, prenatally and postpartum. There is one other tool that was developed by a nursing researcher, but it's one that you have to purchase to use. And I haven't even been able to, I'm sure it's very good because she's a very good nursing researcher, but I don't know of many programs that use that screening tool. So PMAD interventions, basic mom care, especially in the postpartum period, help with the baby care, help with helping her get good sleep, and support and for taking care of the baby, support at home. One of the good things that came out of COVID, I thought, was the number of online support groups that grew for moms who were pregnant or postpartum. And those groups can be in person or online. And so that moms who have anxiety disorders or depression often find it difficult to leave the house to go attend a support group. So it's very helpful if they can do it online. And we had some moms in NFP who would do it online and not even want to show their face, but they still got a lot out of the support groups. They could control more, the way that they participated in those support groups. Perinatal provider support. And that's getting better for obstetricians. Midwives are very good at providing provider support, have been traditionally because they're so woman focused and family focused. Referral to counseling and therapy is hard. There just aren't enough therapists trained to appropriately work with perinatal moms. One of the things that Tucson Postpartum Depression does, the coalition that I am board member of, is to try and increase the availability and the resource list available to moms seeking help and therapy. And we don't limit ourselves to psychotherapists or psychiatrists. Doulas, physical therapists who do pelvic floor exercises and things like that. We make available the information about a whole range of therapies for postpartum moms. Medication is important. If moms are seeking help, therapy, I mean, you can never give medication without therapy, or you should not. The two need to go together. Just throwing medication at someone is not going to help them with their depression and anxiety. And of course, some moms need all of the above, and they deserve all of the above. Barriers to care are limited resources, and traditionally OB coverage with insurance, and used to be with obstetricians, would end at 6-week postpartum. But we know that postpartum depression can occur up to 1 year postpartum. So ACOG is working on that. I hope they make good progress. Therapy is expensive. Many therapists do not take insurance, and so it's kind of self-pay. Fear of moms, again, have that fear of medications, especially if they're breastfeeding, and they have fear of the medications that they're taking. And also a huge barrier can be the length of time from making an appointment to actually seeing a mental health professional. And that first visit will be a screening visit. And then there may be another delay until that person is matched or can begin seeing a therapist regularly. And that's really difficult when a mom is in crisis. I mean, she's having severe anxiety or severe depression. And if she's psychotic, all you can do is take her to an emergency room and hope that she gets some appropriate care. There are very few psych units that are appropriate for the care of postpartum women and their breastfeeding babies. That's a very high bar for psych hospitals. And there are varying degrees of knowledge base regarding PMADs among therapists. And moms may be resistant to screening because of the stigma of having a mental health label. And again, hospitals inadequate for a pregnant or postpartum mom with unique needs, because they may not get a private room, and they may not be able to see their baby. And if they're breastfeeding, they might not have access to a breast pump or breast pads, or if they're still bleeding, peri pads. It's really it's a very difficult thing for moms who need inpatient care. So, but I wanted to go over postpartum resources with you. The main one in the US is the Postpartum Support International, PSI. They have an incredible online presence. They were founded in 1987 in Portland by a woman who thought that we needed to do something about postpartum and postpartum depression. They have a helpline, online support groups, and local and state PSI chapters. We have a local chapter here in Tucson, and then we have a very active Arizona state chapter. So if you go on PSI, you can find the location and contact information for those chapters in your own area. And they also provide the gold standard for training in perinatal mood disorders. And you'll find information about that also on postpartum.net. It's a 2-day program, for basic 2-day program. And for providers like therapists and things like that, there's a 3rd day. And also, if people are prescribing meds, there's a section for people who prescribe meds on the 3rd day. So they can learn about that. But that PSI has the gold standard for anyone interested in getting training in caring for postpartum depression moms. Mother to Baby is a US-wide helpline. It's under the auspices of the Organization of Teratology Information Specialists, and they provide information on the safety of medication, chemicals, herbal products, illicit drugs, and diseases during pregnancy and postpartum. And they have resources in both English and Spanish. There are crisis and helplines for postpartum, National Maternal Mental Health Line. Again, you can call or text in both English or Spanish. And HRSA, which is the Health Resources and Services Administration of the US government, has a hotline. Again, you can call or text 24/7 in English and Spanish. And then if a mom's really distressed and threatening suicide, the Suicide and Crisis Line that it was set up just a few years ago is 988. Local support groups are really important, in person or virtual. Oftentimes, hospitals that have maternity units or perinatal units will have a postpartum support group or a breastfeeding support group. And some also have a grief or bereavement support groups for pregnancy loss. Or they may be out, these groups, especially the pregnancy loss groups, may be out in the community rather than hospital or clinic supported. And then PSI also has information on support groups. For healthcare providers, OBGYN physician, a certified nurse midwife, or a lay midwife, as well in states where those licensed midwives practice. And pediatricians are the healthcare providers to look for. Also psychologists, psychiatrists, licensed social workers, LCSW are also able to do therapy. Psych mental health nurse practitioners, they now have a specialty for perinatal mood disorders, and then physical therapists who can do body work on the pelvic floor for moms who are still having physical distress after having a vaginal delivery. And and a mixture of those. It's not like there's any one road or pathway or too many helpers that a mom can have, because she may have several complex needs for healing from postpartum depression. For community health home visitors, the new parent support program in your community is a good one. That's for if you have military families in your area. That's the program that focuses on new parents. Nurse Family Partnership, Healthy Families, Healthy Start, your county health department, and regional behavioral health department may have resources for moms as well. Also doula and lactation support. Doulas are wonderful during labor and delivery. I always enjoyed working with doulas when I was a labor nurse. And they can provide childbirth education, birth support, postpartum support, and grief and bereavement support. And also, not to forget, our IBCLC certified lactation consultants can be tremendous help, and especially in the postpartum period, because you can combine. There's a lot of postpartum support that can come with having a lactation consultant, either in home or going to a lactation clinic. We have lactation clinics in all of the perinatal unit hospital sponsored programs in Tucson, plus a private one out in the community that is wonderful. For IPV and DV, community resources include the local support and shelter services, also child protective services, especially if your mom is an adolescent, and then adult protective services for elder adults, if they are being exploited or abused by a caretaker or family member, which is most common. Online resources include the National Domestic Violence Hotline, the National Coalition Against Domestic Violence, the Family Violence Prevention Fund out of San Francisco, the National Resource Center on Domestic Violence, the National Center on Domestic Violence and Sexual Violence, and Domestic Violence Resource Center and Women's Law, as well as those similar or parallel resources within your own communities. And here are the references. So that is it for me.